Center. Her specialties include neurology, neuromuscular medicine, neurophysiology. Dr. Ziong primary care areas include neuromuscular diseases such as neuropathy, myopathy, neuromuscular junction disorders, amyloidosis, motor neuron diseases, and her research interests include neuropathy, myopathy, myasthenia gravis, and familial amyloidosis. So without any further ado, I wish to welcome Dr. Ziong, and I will stop sharing and let her share her screen with us. So thank you very much for doing this talk and for sharing the wonderful information on neuropathy with us. Dr. Ziong.
Thank you very much for the invitation. I will start sharing the screen shortly. And I'm really honored to discuss with you, the whole community, about neuropathy here at Western Neuropathy Association meeting. As you know, I work at Neuromuscular Division at Department of Neurology, University of California, Davis. We manage various neuropathies in our clinic and hospitals. We would like to appreciate you for your interest to learn more about neuropathy. Hope this short talk will be able to offer a little bit more information to you today. So just to start my screen sharing. Can everybody see the screen good now?
Yes.
All right, good. All right, so this is a cartoon to show you our nervous system. As you know, our nervous system is quite complicated. The brain and the spinal cord are the central nervous system. Then what are those bundles coming out of the brain and the spinal cord? Those are our peripheral nerves. The peripheral nerves are the bundles distributing all over our body, collecting information from outside world and internal organs, and also conducting the commands from the brain and the spinal cord to perform the duties to keep our body function appropriately. So what does the nerve look like? This is a nerve in the arm, and you can see the nerve look like a bundle of electric wires. One single nerve fiber contains the outside layer we call myelin, and the inner part of the core we call axon. So the outside myelin protects the axon. Then what is neuropathy? So the neuropathy is the function abnormality of the nerves we just saw outside of the brain and the spinal cord. Then what causes neuropathy? Well, there are multiple reasons. There are two big categories of neuropathy. One category we call hereditary neuropathy, that is caused by genetic mutation. It could be from your parents or just some thing happen very suddenly while you were a baby, even not necessarily from your parents, because the human genome can have a spontaneous mutation. And the other category is called acquired neuropathy. That means it's not from genetic mutation. There are multiple causes, including trauma, infection, metabolic or nutritional abnormality. Sure, some toxins, including certain medications, can cause nerve damage. In the inflammation or immune-mediated process could also cause neuropathy. So what are the symptoms of neuropathy? Well, it's complicated. We have some patients may have a positive symptoms. They feel their nerves are irritated. They get tingling, burning sensation, or pain, severe nerve pain. And sometimes some patients may have a muscle cramp that could be also from a neuropathy. There are negative symptoms, including numbness, weakness, and the loss of a balance. Some patients may have autonomic dysfunction. That means our internal organs are not working properly. For example, some patients will have too much sweat, or some patients will not have adequate sweating, the sweating glands dysfunction, and some people may have bowel or digestive problems like constipation, diarrhea, or indigestion. Certain patients may also have a blood pressure or heart rate fluctuations significantly, all kinds of symptoms. But we know all those symptoms are not quite specific, because certain symptoms like pain or muscle cramp could happen in other diseases, not necessarily neuropathy. The sweating gland abnormality is not necessarily quite related to the nerve damage either. As you know, constipation, diarrhea are very non-specific presentation. So that's not very easy for people to achieve the diagnosis of a neuropathy, right? So that is why it is important for us to visit doctors whenever you have the symptoms that could be neuropathy. Then why we would like to visit the doctors when there are symptoms of neuropathy, because we want to achieve early diagnosis to confirm those symptoms are caused by nerve damage. And also we would like to find the cause of neuropathy. Then we can start some early intervention to slow down the progression and improve life quality. Sometimes we may not be able to find the course of a neuropathy for everybody. We call idiopathic neuropathy, but we may be able to provide some management to help relieve some symptoms. Then how do we diagnose neuropathy? Well, for sure, if you have symptoms possibly suggesting neuropathy, you would like to visit a primary care doctor first, because your primary care doctor will be responsible for your general health. They can obtain some common lab tests to have the first screening, and then your primary care doctor may refer you to the neurology clinic. You do not really need to see neuromuscular specialists for all the neuropathy. The general neurologist can diagnose and treat common neuropathies. But when do you need to visit a neuromuscular specialist? For certain situations? For example, some type of a hereditary neuropathy. Right now, we have a few hereditary neuropathies that may have special treatments or have clinical trials that could be beneficial for certain hereditary neuropathies that are caused by genetic mutations. And if you have a certain, hereditary neuropathy need a special treatment, it's really helpful to visit a Muscular Dystrophy Association clinic that will offer many resources as well as multidisciplinary care. That means multiple specialists will be in that clinic to offer different managements to care about your neuropathy. And certain uncommon acquired neuropathy will have some special treatments like inflammatory or immune-mediated neuropathy. We always collaborate with rheumatology or immunologists to start some special immune therapy. And I would like to briefly mention about amyloidosis neuropathy. This is a very specific rare neuropathy. At UC Davis, we have a multidisciplinary team to manage this special neuropathy. And we collaborate with oncology, cardiology, specialty pharmacy, as well as nephrologists to help the patients with amyloidosis neuropathy. Then how can you reach a neuromuscular specialist? Well, your primary care doctor or your general neurologist could send referrals to neuromuscular specialists. And you can also look at the MDA website if your neuropathy condition is fitting the specific care within the range of an MDA clinic. You can find the care center list on MDA website. And also you can now Google online to look for neuromuscular division in Department of Neurology at different institutions nationwide. Kaiser is a private practice institution. It also has a neuromuscular specialist. Many academic centers, like the university hospitals, for sure they have a neuromuscular division. So those are helpful resources online. Then how do we diagnose peripheral neuropathy? You may realize that whenever you visit a neurologist in clinic, the neurologist always asks you, your clinical history. Even, we received a referral from your primary or general neurologist. We always want to ask your own story because we would like to obtain as much as possible about your information to help us guide the diagnosis. And we will perform physical examination, including neurological examination. We can order some lab tests. Those lab tests could be ordered by primary care doctor, like certain routine labs, blood routine, comprehensive metabolic panel, and A1C, glucose tolerance test, thyroid function panel. The vitamin test will be helpful. Usually we order B12 or thiamine. Sometimes we may add B6. We also screen for a certain type of inflammatory markers like C-derate, C-reaction protein, anti-nuclear antibody. We also perform a special blood test to look at the unusual protein band in the blood. As we talked previously, certain infections may cause neuropathy. So we also order some infectious tests that could cause neuropathy to see if there's any infection possibly can be treated to help the neuropathy. And many patients probably already know that EMG nerve conduction study is a really important diagnostic tool to achieve the diagnosis of neuropathy. Unfortunately, this is a painful procedure, not comparable, although many people can tolerate that, but it's not a pleasant experience for sure. Some patients, we may perform lumbar puncture to collect the cerebral spinal fluid test for further evaluation, but we don't need to perform lumbar puncture for all the patients. Only a small percentile of the patients with the neuropathy will need further evaluation from the lumbar puncture. Sometimes we may perform imaging study, including special ultrasound and MRI to look at the nerves, especially when the patients have trauma or injury to the nerves, that we would like to have a certain information to see where is the trauma, and is there any mass compression. Rarely we perform nerve biopsy to look at the nerve directly. We don't need to perform nerve biopsy in majority patients with a neuropathy. Only very, very unusual occasion we perform nerve biopsy. And usually I will talk to the patients to let them know what are the, possibilities for the nerve biopsy will reveal. Nowadays, the genetic tests are relatively convenient, and we have to be careful when we have the genetic test done to look for the hereditary neuropathy, because the genetic test could reveal positive result that show which genetic mutation caused the neuropathy. But it could also report something not clear enough. The most common situation is a variant of unknown significance. That means certain nucleotide change was detected, but we are not sure if that change will cause abnormal mutation to cause neuropathy. So it's unclear when there is a variant of unknown significance. We don't really have special management or special interpretation. For sure, for the negative results will be reassuring. This is not hereditary neuropathy caused by genetic mutation. So I will talk a few common types of neuropathy to offer you a little bit more information. So the metabolic neuropathy is pretty common because many patients come to our neuromuscular clinic have diabetic neuropathy. The diabetic neuropathy can present about half of the diabetic patient population. There are different types of diabetic neuropathy, it is a really common complication. So not all the patients with diabetes develop diabetic neuropathy, right? Then what are the risks for the patients with diabetes to develop a neuropathy? So first of all, the poor control of the glucose level. So it's always important to track the glucose level and make sure the glucose has been under good control to reduce the risk of diabetic neuropathy if a patient has diabetes, or so some other disease situation like hypertension, high cholesterol, obesity, and smoking are risk factors in patients with diabetes that could develop neuropathy. The most common type of diabetic neuropathy is what we call chronic sensory motor neuropathy. It affecting the sensation more than the strengths. It look like the patients getting sensation abnormality in their lower extremity, like wearing long socks, or in the hands, when the neuropathy is getting worse later, like they are wearing gloves. The patients could have the sensation come up to the chest level or belly. Sometimes we call wedge-shaped sensation abnormality. Rarely the patients with the diabetic neuropathy can have the neuropathy occur very acutely or suddenly. Usually the patients have a really severe burning pain and hypersensitivity, even with a really mild, touch. Those situation is worse at night. Because of the severe burning pain, the patient may get significant depression and weight loss. And usually the acute sensory neuropathy occur when the patients with diabetes have a very bad glucose control. Sometimes they may have an episode of ketoacidosis before they develop the acute sensory neuropathy. The chemotherapy-induced neuropathy is relatively common. That's one of the most common neurotoxic toxic neuropathy. Because nowadays, with all kinds of chemo agents application to treat cancers, more and more patients start to suffer from the chemotherapy-induced neuropathy. The incidence varies differently in different chemo agents, could be 10 to 100 percentile. The risk factors for the patients who receive chemotherapy that will develop a neuropathy, including diabetes, alcohol use, and the poor nutrition, especially the B12 deficiency or certain type of an infection like HIV. The older patients usually are, tend to develop a chemotherapy-induced neuropathy after the chemotherapy because their nerves are more fragile than the younger population. So far, we don't know why the chemo agents will cause the nerve damage. And most of the time, it may not be completely reversed. Even the chemotherapy was discontinued. So the chemotherapy-induced neuropathy may happen during the therapy or after the therapy. Sometimes it even happen, a few years after the therapy stopped. For sure, with a higher dose, the nerve damage will be more significant. So when the patients with cancer develop chemotherapy-induced neuropathy, the dosing could be readjusted if necessary, or the chemo could be switched to another type of treatment. Nutritional neuropathy nowadays is less common, but it's still an important cause of peripheral neuropathy. The common deficits, including B12, thiamine, B1, B6, and vitamin E, usually is related to insufficient intake from the food or other nutritions, but it could be also from malabsorption. Especially some people get chronic diarrhea or have some chronic GI problem like atrophic gastritis, and some young patients may have toxic side effects from nitrous oxide abuse. That's another risk factor for nutritional neuropathy. It mainly affecting the sensation. So for the nutritional neuropathy, we offer the supplementation of the deficient nutrition, and also it's important to visit the dietitian to help the general health to have better nutrition, not only just the vitamin. So hereditary neuropathy is relatively more common in younger population, but that is really important cause of the neuropathy. The most common hereditary neuropathy is the Charcot-Marie-Tooth disease. Some patients may be eligible for clinical trial. There are many different subtypes of Charcot-Marie-Tooth disease we call CMT, and some patients with CMT may start the disease relatively at older age, like 30s, 40s. So those are relatively uncommon situation, but we do have some clinical trials now. Could be potential hope for the patients with hereditary neuropathy, especially the CMT patients. Certain patients may have a hereditary neuropathy with a liability to pressure. That's another genetic disease, a real it requires the genetic test to confirm it. The familial amyloidosis polyneuropathy is the one that I will talk in a little bit details later, because this rare neuropathy start to have really exciting treatment in this, and this is now the only hereditary neuropathy that has special treatment approved by FDA. So what are the managements for patients with a neuropathy? Well, we always offer physical therapy, occupational therapy to help the weakness and also try to maintain the function. Certain patients may need a special orthotics like ankle brace if they have a foot drop and a wrist splint or elbow pad. So wrist splint usually is applied for the patients with carpal tunnel syndrome. Elbow pad will be helpful for patients with ulnar neuropathy that compress at the elbow. Those situations that usually happen when the patients are, using the hands a lot or have, the habit to compress the elbow or wrists repetitively. We also have certain medications that could help neuropathy symptoms, like gabapentin, pregabalin, Lyrica, are the first-line treatment for patients with neuropathic pain. Duloxetine is antidepressant, the commercial name called Cymbalta, is also used to treat neuropathic pain. Amitriptyline, nortriptyline is another type of antidepressant that will be helpful for neuropathic pain or tingling. There are some, anticonvulsant medication used to treat the seizure that may be applied in some patients, rarely, to help to control the neuropathy symptom of tingling pain. Alpha-lipoic acid is not a medication, it's an antioxidant. It may help improve the symptom of numbness, tingling, and pain. There is a small clinical trial done before in patients with diabetic neuropathy showed some improvements of pain control, although individual response could be different. Some patients do not like to take medications because the side effects profile. So we also recommend a certain type of a topical cream. Lidocaine, capsaicin creams are the commonly used one. Those topical cream will not really be long-lasting, but will be helpful, especially the patients have significant side effects to the oral medications. So neuropathic pain control is a common question in our clinic. Although we are not pain specialists, we usually talk with the patients about the medication choices, including the one we just talked in the last slide. However, some patients may not be able to having good response for those commonly used medication for neuropathic pain, or they could not tolerate the side effects. So then we send the patient to pain clinic to specifically address their pain control. The pain clinic have medical choices, like medications, all kinds of medications, including the oral medications or infusion medications. But the pain clinic could also offer some non-medical managements, including behavior therapy or biofeedback. Nowadays, California also approve alternative medicine to help the neuropathic pain control. So we do have patients at a pain clinic who can receive a transcutaneous electric nerve stimulation TENS unit to help reduce the pain. And certain patients may try acupuncture. And there are some reports about the application of a transcranial magnetic stimulation to help pain control. Although right now, I don't think our institution, University of California, Davis, is offering the transcranial magnetic stimulation. It could be possible choice in future. Maybe this need more research, also the clinical trial so far. So there are certain special treatments for some unusual, neuropathy or different types of neuropathy. Like the diabetic neuropathy, as we mentioned, glucose control is really important. Nutritional neuropathy, we emphasize the nutrition supplementation. In the toxic neuropathy, for sure, you want to stop the toxin exposure. Infectious neuropathy, we will treat the infection. The inflammatory or immune-mediated neuropathy will need immunotherapy. The immunotherapy itself does not regrow the nerve or repair the nerve. The immunotherapy just reduce the inflammation or cool down the immune reaction to let your body repair the nerve by itself. But that's important because with ongoing inflammation, the nerve damage will be more and more significant. The immunotherapy may stop the inflammation or slow down the inflammation to offer time window for the nerve to repair. Traumatic neuropathy, depends on what type of the trauma, like a carpal tunnel syndrome. If that's severe compression, the patients could improve with a compression release surgery. And some patients have a really significant injury from motor vehicle accidents. We may refer the patient to plastic surgeon or neurosurgeon to do some special nerve repair. But the generalized neuropathy, like diabetic neuropathy, we don't have the methods to do any specific nerve repair. So now I would like to talk briefly about familial amyloidosis polyneuropathy. The abbreviation is FAP. This is a really rare hereditary neuropathy. Most of the time, the patients have a family history. It happens in each generation. That means, it happened in grandparents, and then it occur in parents, then come to the children. But there are sporadic cases reported before. It is caused by transthyretin TTR mutation. This is a worldwide disease. First, it was identified among Portuguese, and then we identified this special hereditary neuropathy in the United States. In the other European or Asian countries, African Americans or African countries. So this disease will affect multiple organs in the systems, including nervous system, gastrointestinal tract, heart, kidney, and eyes. This is a rare disease. Previously, without the treatments, the prior treatment is mainly liver transplantation. Without the treatment previously, the patient could die within 5 to 10 years with the rapid progression of neuropathy. So we do have the new breakthrough for the treatment of disease, applying the genetic therapy. FDA has applied RNA interference treatment to treat FAP. Nowadays, we have another strong gene editing tool, CRISPR-Cas9. That's the really strong tool to edit the human genome or other animal genomes. So Dr. Carpenter and Dr. Doudna are the pioneers to develop this strong genetic editing tool, and they won the Nobel Prize in Chemistry in 2020. So there are some other scientists also made significant contributions to bring this strong tool to our human disease application, including Dr. Zhang from MIT and Dr. Church from Harvard University. So now I would like to show you a video how this revolutionary tool is affecting our advancement of the genetic therapy for the hereditary neuropathy. Okay. Let me switch to another screen. All right, let's just go back to my prior slides. Well, the question is when and who will apply this tool? Well, for sure, we would like to use this strong tool carefully in the patients with a certain hereditary disease will be able to benefit the revolutionary therapy. Right now, the FAP clinical trial for the CRISPR-Cas9 gene editing system is only in phase 1, and there were two groups of patients. 6 patients received the treatment with this strong gene editing tool. The patients had the abnormal protein knocking down, and then the dose of the concentration of the abnormal protein production significantly decreased after just a single dose of the treatment. So we know this is not perfect for the tool. The tool is not perfect so far, but we are still, working hard to see if we can make the treatment, better. And at the same time, really be careful, don't apply in a certain situation that will not be legal. Okay. All right. So this is my presentation. Thank you very much. And I would like to acknowledge in my department for the support of the neuromuscular clinic, as well as my colleagues the collaborators to help care of the patients with neuropathy in the audience. Thank you.
Thank you very much, Dr. Ziong. At this point, we would like to open the floor to questions. And I know there's a few of them in here. So unless somebody else wants to do this, I'm just going to jump in and start asking some questions here that are in the Q&A. One of our participants asked, can you give an example of metabolic nutritional abnormalities as a cause of neuropathy? And I think you did, but I mean, you might want to reiterate some of that.
Well, the common metabolic abnormality cause neuropathy is diabetes and some other metabolic abnormality, including, uremia, the kidney dysfunction. Nutritional abnormality is pretty common, including multiple vitamin deficiency. The one that I listed in the slides, are the commonly encountered one: B12, thiamine, neuropathy. Okay.
And another question is shaky hands a symptom of neuropathy?
Well, this is a very nice question. So I will say, if you refer shaking hands as tremor, then usually tremor is not a symptom of a neuropathy. And some patients could have a little bit tremor when they have a certain type of a neuropathy. We do see some patients with a CMT, whereas special subtypes of a CMT present with a little bit of mild tremor. But the tremor is not the only symptom for those patients with a special CMT.
Next question is, why is there such an inconsistency in testing for neuropathy by different neurologists, different findings and conclusions?
I'm not quite sure about this question. Like the blood tests, so different labs have different standards. That is true for like the blood tests, but usually they will offer some reference range in different labs. The EMG nerve conduction, I will say we do have some different standards in different institutions, or the normal range, because the human population is so heterogeneous, or we are not the same person. No, we try to find a normal range. So usually we define the normal range based on a population around our community. But you can see we have a different ethnic backgrounds, and it may exert a certain difference for the normal range. For example, so I used to work at the East Coast. I can tell you the normal range of the nerve conduction test is different from my current lab. But both institutions are, credentialed institutions. And sometimes we may see certain, different criteria, but in general, our standards are similar. We cannot say, they are the same all the time, because, for example, some people, with a small size, you cannot really imagine the nerve diameter will be the same as a larger size person, right? Mm-hmm. In theory, nerve conduction velocity or nerve response amplitude will be sort of like, the same, but that's really just in theory. So the normal range could be, evolving over time or over years. And we do have some, updates of, the diagnostic criteria for different types of neuropathy over time. Like, the one we probably, have updated the diagnostic criteria several times in the past 20 years, like a chronic inflammatory demyelinating neuropathy. This is a case. So it's not an issue with, sort of like different opinions, but I think also the disease itself evolving. So initially the test could be normal, but over time with the symptom progression and the test, when you get repeated, it could be different.
Okay, thank you. So the next question is danger of nerve biopsy.
Well, this is an invasive procedure, so we usually don't, do this procedure unless this is truly necessary.
Okay, and the next one is, does elevated A1C and sugar consumption cause peripheral neuropathy symptoms in patients who are not diabetic?
Oh, well, this is a very good question. This is a situation with a pre-diabetic, condition. So we do have a patients who have a neuropathy with a pre-diabetic condition. Is there any established causal relationship? I can only say, the underlying etiology of diabetic neuropathy is not quite clear, but the glucose level has been, not really healthy for the nerve in the long term. So even the patients are not meeting the criteria for diabetes, but the glucose level was not normal, that may cause a certain pathophysiological change that may not be good for the nerve health. So is there any established causal relationship? I will say we don't have that strong evidence, but it could exert some bad effect for the nerve health in the long run. Even the glucose level is just relatively elevated, not to the range of diabetes range.
The next one is, can some nerve damage be repaired, or more specifically, can neuropathy be reversed?
Well, depends on what caused the neuropathy. Certain patients with traumatic neuropathy, we do have some surgeons could do nerve repair, but we don't have the approach to repair the diabetic neuropathy. Can neuropathy be reversed? I will say in majority cases it cannot, especially when the damage comes to the inner part, the inner cord, axonal part. The outside part, myelin damage, could be repaired by the body itself. There's no medication specifically regenerate the nerve or myelin. It's your own body. But usually the myelin repair by your own body may not be complete.
Okay, the next question is, what about cryoattenuation?
So I'm not quite sure about this question. The is the management sort of like use a certain the cryotherapy to reduce the nerve pain, because this measure I had never applied, so I cannot really comment on this one. But I heard some patients mention about, this intervention. I'm not sure if the pain clinic is doing this intervention. At least at UC Davis, we have not adapted the cryo attenuation.
Okay. Next question is there something we can do to regrow, repair, or our peripheral nerves? What are the possibilities and the time frames? I have unknown peripheral neuropathy, as many do.
As we just mentioned, in general, we don't really have any medication to regrow or repair the peripheral nerve. So for the traumatic neuropathy, like, a patient gets the nerve caught from a car accident, the plastic surgeon or neurosurgeon may be able to reconnect those, nerve damage. But, for the general chronic neuropathy, we really don't have a one, that can be applied.
The next one is, what is nitrous oxide abuse?
Well, this is not that uncommon now. So some people may, sort of like inhale the laughing gas. Well, if you are in the dentist, office to do procedure, get some, some laughing gas is not a big issue, but some people are sort of like, to inhale laughing gas intentionally for their, spiritual, is sort of like a drug abuse. So that nitrous oxide abuse could potentially cause B12 deficiency.
Okay. Is EMG a negative? If EMG is negative, can there be an impediment of nerve at the ankle area? Let me read that again. If the EMG is negative, can there be an impediment at the nerve at the ankle area?
I don't really quite understand this question. So EMG test is more functional test. It does not showing the structural abnormality. We have to, be aware of that. The structural abnormality, the EMG test will not be able to see the impingement or, the nerve damage in certain structure directly. It's just showing the function damage. If you are thinking, there is a possible nerve compression at the ankle, EMG will be helpful for the functional part to see if there's a, compression. If, you would like to see structurally the compression, then the imaging test will be helpful.
Okay, the next one is, I think you basically answered this one, but will there ever be a real treatment for PN?
I'm not quite sure about this question. If we do have a treatment, the current treatment mainly targeting on the symptom control.
Yeah. Okay. So another one said, I meant to say unknown etiology, I guess having to do with the previous question. I'm not sure how to connect it. What about platelet-rich plasma therapy?
As far as I know, we have not really applied this type of a therapy as the treatment of a neuropathy management.
Okay. If neuropathy is circulation related, can the body repair nerves with circulation improvement?
I cannot really say neuropathy is caused by circulation problem because right now the course of neuropathy, as I listed in the presentation, are not really including the circulation. But it may, have sort of like, a certain situation, the microcirculation, like some patients with diabetes, the microcirculation may not be good, then the nervous in that small area could be, impacted, but we don't know because we don't have clear answers for all those questions. We have scientists doing researches to try to understand all the courses, but I don't think we have the clear answers for all the courses of the neuropathy.
Okay. I just want to ask, let's see, there's another one here. I just see a new one that says in the rebuilder unit, which is a mechanical device that's used to help rebuild nerves. There are 3 settings. In your opinion, which is the best for peripheral neuropathy? TENS 1, EMS 2, and 3 is 7.83 hertz. I guess I'm not sure how to answer this, or even what, unless you understand and have a working knowledge of the rebuilder.
Well, we usually don't, deal with this situation because usually if a patient needs to, do certain type of whatever we call non-medical approach to help the peripheral neuropathy, I generally refer the patient to pain clinic or rehab department because they are the experts dealing with this type of instruments specifically, and our major task here at the neuromuscular clinic mainly is to make the diagnosis and offer the common medical managements for the symptoms.
Okay, thank you.
Thank you.
Now, just one last thing I'm going to ask is anyone that has any more questions or comments to please quickly put them in. If not, we will proceed on. So at this point, I don't see any more. So I think what we're going to do is say thank you so very much for your presentation. It's very appreciated. And we appreciate that you took time out of your busy day at the medical center to provide this good overview and comprehensive review. Thank you very much again. And please have a very good day. And thank you for participating in our virtual conference.
Thank you. I greatly appreciate this opportunity to share the information with the community, and hope we have better research in future and more advancements in the neuropathy managements. Okay.
Thank you.
Thank you. Hi. You all have a good day.
All right. Thank you.